Hey class, Dr. Dorf here. As promised, a follow-up to the JNC 8 lecture, this one covering ATP3, which focuses on lipids. Now, the ATP3 guidelines, they kind of read like stereo instructions. I'll give you that. We'll try to go over some of the highlights here. I also want to go over something that is important in terms of practice, that is basically, some people refer to it as ATP4, although it's not officially ATP4, but it came out in 2003, updated guidelines regarding management of dyslipidemia. We'll talk about some of the differences, but for testing purposes, for the purposes of boards, you will need to know ATP3. So just a quick reference. I don't know if you download the full ATP3 guidelines. It's something like 60 or 70 pages. But it primarily focuses on LDL goals. So the first step is determining LDL goals. It talks about a 9 to 12 hour fast. You can get away with a 6-hour fast, but for testing purposes or a board question, it needs to be 9 to 12 hours, and it defines your primary targets for your LDL, which we know is your bad cholesterol, L standing for loser, your total cholesterol, HDL being good cholesterol. So then you identify the presence of any atherosclerotic cardiovascular disease. Or risk equivalent. Symptomatic carotid artery disease, PAD, or someone who is rocking a AAA. Then you look at risk factors. Again, you guys can read those. A lot of it has to do with hypertension, HDL, if they're a smoker, non-smoker, age. There's a calculator you can plug all this into, by the way, which I'll talk about later. So you kind of start calculating out these risk factors. This gives you your 10-year risk. What that's saying is that's a 10-year risk of having a cardiovascular event, heart attack, or stroke. It's also called your Framingham calculator or calculation. A lot of you guys may have this built into some apps that you already have. If not, there are plenty of free ones out there. CV Calc is one that comes to mind, but nothing you have to spend money for in the App Store or the Android Store. So then you kind of classify these folks in their risk category in terms of where they fall, where you base them, greater than 20%, 10 to 20, or less than 10% risk, where their score is at. And then it talks about at what level you initiate therapeutic lifestyle changes, which are lifestyle modifications, diet, exercise, weight loss. And then you get into what levels, based off of solely LDL, where you're going to start drug therapy. So there's your lifestyle modifications. We all know that. So if they don't get to gold, then you add one of these following classes. So again, you're not going to need to know exact specific drugs and dosing at this point. You will eventually, as you get further along in the program. But you need to know classes in terms of what your statins are, which is pretty easy because they all have the word statin in them for the most part. Your bile acid sequestrants. So that's Questran, Welcol. These are some of the generic names here. These can also be used for other things that work well in people that have dumping syndrome after they get their gallbladder yanked and are having a lot of diarrhea. You can use bile acid sequestrant. Sometimes you can use it for people with prolonged diarrhea. Your nicotinic acid, that's niaspan. There's a regular release, there's extended release. Sometimes you see this compounded with other medications, with statins. And then your fibric acids. These primarily work on triglycerides. You can see right here, big decrease with trigs, not so much in terms of your overall cholesterol. So anyway, so know your classes here. and of course some of your side effects and contraindications. But I'm not going to hold you responsible for specific drugs and doses at this point. So then you look at metabolic syndrome. How much have we talked about metabolic syndrome so far at this point in the semester? So of course that plays a prominent role. We should already pretty much have this down in terms of how to identify our metabolic syndrome patients. Talks about treatment of elevated triglycerides. As we just know from our GI module, not only elevated triglycerides play a role in terms of cardiovascular disease, but they're also at significantly increased risk for developing pancreatitis with high trigs. So this goes through what levels you treat those at, and what you use to treat. So again, you see statins not really frontline here with trigs if we're just treating trigs, nicotinic acid, or fenofibrates. There's your calculator down here, that Framingham score. Again, there are apps that are for this, so I really wouldn't spend a lot of time looking over this. I would just download one of the free apps. You're able to calculate the 10-year risk. So this is a nice quick reference guide. I would download one of these in a PDF form and use that to refer to when working on your CDM and when looking over and reviewing ATP3 guidelines for testing. So the addendum to that you will be seeing in clinicals, if you haven't already, especially next semester when you start getting into specialized clinicals, if you're spending time with a cardiologist, or if you currently work in an area that whether it be CCU or CVICU or anything like that. This is what you see primarily in practice. And it goes against ATP3 guidelines to a degree. These came out, ATP3 guidelines came out end of 2002, early 2003, I believe. So they're dated. They're over a decade old. In 2013, the American College of Cardiology, ACC, and the American Heart Association got together and proposed these new guidelines that they entitled blood cholesterol guidelines. They actually approached the folks that wrote the ATP3 guidelines and proposed this as being ATP4. However, they couldn't agree on the language. They couldn't agree on the way that trials were conducted. The group that developed ATP3 guidelines were unwilling to recognize this or adopt these guidelines as being official new guideline management for dyslipidemia and stamp it as ATP4. However, you send a patient to a cardiologist, and even in most primary care settings, this is what most people are going by in terms of treatment. Again, if you download this off of the ACC or the American Heart Association website, it's, I think, 85 pages, 86 pages, something like that, and again, it reads like stereo instructions. You get some of my, let's see, I think this one's actually even better than the last one, so I'm going to say I've made it to junior high now in terms of my chicken scratch. So some junior high level handwritten chicken scratch here. So the major difference between ATP3 and the 2013 ACC and AHA guidelines is that they no longer will treat to LDL targets. You saw in the PDF that I just put up how everything was very specific, focusing on LDL targets, what you had to get them down to. So they came up with 4 major groups that they identified. This also, the main focus of these guidelines is it's statin-based. Statins first, statins first, statins first. Even just this year, your American Academy of Endocrinology, the folks who, of course, we manage our ACE guidelines for management of diabetes, they did studies as well, which they now push for advocating starting statins sooner in somebody who is diagnosed with diabetes. regardless of whether they have a god-awful lipid panel yet or not. So, but anyway, that's beside the point. Diabetics do fall into this. But so there's 4 groups here. Your first group is the one up here in the upper left. So these are people that already have been diagnosed with clinical ASCVD, atherosclerotic cardiovascular disease. Okay, an example of that is CAD, coronary artery disease, previous stroke, peripheral artery disease. Somebody who's had a MI obviously would fall into this category. So this is regardless of age. If they have clinical atherosclerotic cardiovascular disease, they fall into this first group, box number 1. Right over here, box number 2 are any patient that has an LDL greater than 190. So they kept the theme of LDL from ATP3. They just don't get so specific in terms of targets, though. So LDL greater than 190 or clinical ASCVD. These patients are to be started on high-intensity statins. The reason being is they found that the high-dose statins will lower LDL by greater than 50%. The 2 main frontline statins that are leading the way here, atorvastatin, which Lipitor, 40 to 80 milligrams, and rosuvastatin, which is Crestor, which is your real big gun, big dog statin, 20 to 40 milligrams. So these 2 groups in boxes 1 and 2, they get high-intensity statins. All right. Now that brings us down to our next folks down here in boxes 3 and 4. Over here in the lower left, we have our diabetics. All right, diabetics that are between the age of 40 and 75, with an LDL between 70 to 189 milligrams per deciliter. Or your non-diabetic, any patient who's 40 to 75, same LDL here, 70 to 189, but they have a 10-year risk, that calculator that we talked about before, Framingham score. They have a 10-year risk of developing ASCVD. That 10-year risk is greater than 7.5%. So these 2 groups get started on moderate intensity statins. These will lower your LDL 30 to 50%. So you still have atorvastatin and rosuvastatin, your Lipitor and Crestor, but low dose. All right. Simvastatin comes into play here, 20 to 40 milligrams. Pravastatin, 40 to 80 milligrams. Lovastatin at 40 milligrams. Fluvastatin at 80 milligrams. So those are your moderate intensity statins. Now keep in mind, if you look back up above in box number 1, in our patients that have a diagnosis, they already have ASCVD. If they are over the age of 75, you don't hit them with the high intensity statins. You go with moderate. So you go from one of this list down here. All right. And then also down here in our diabetics that we talked about, they get moderate intensity statins. However, if their 10-year risk score is greater than 7.5, they get high intensity statins. Which is what I talked about earlier, that there's been literature that's come out this year now that the endocrinology folks have started to get on board and adopt and adapt, mainly because of the data that came out of this study. So notice that you do not calculate for any of these 2 groups up here. There is no calculation in terms of doing a 10-year risk score because first off, in this group they already have it, so there's no need. And someone with an LDL greater than 190, yeah, they're going to have a score that's probably going to be greater than 7.5. So that's why you don't need to calculate out the scores in these 2 groups. So, again, hope that helps. I will post this along with the lecture. So you now should really have everything that you need to finish up your cardiology module, which hopefully you have a good chunk of that done by now, as its due date is coming up. I hope these two presentations on JNC8 and over lipids have helped. Again, I don't want to confuse you too much by showing you this, but I think it's important because when you get out into practice, this is what you're going to see if you aren't already seeing it in the clinical setting, and it may cause some confusion when you look at this and you're reading ATP3 and you're saying, wait, where's this coming from? Or why is this cardiologist always putting people on 80 milligrams of Lipitor when they've never taken a statin before in their life? Hey, if they just rolled out of the hospital and have had a big old honking MI or stroke or whatnot, there you go. Now you know why. So that's what these are meant for. Again, any questions about any of this? As always, feel free to call, text me, or shoot me an email. You know I'm always here for you guys, and happy to answer any questions. So again, hope you find these video lectures helpful. Please let me know if you do or don't. By the way, either post something like in the discussion board. That way I can take a quick peek at that and look and make sure that everyone has seen this stuff and yeah, hey, you think it's helping, or if it's not helping and it's not helping you out at all, then I'll quit doing them. We'll try to find some other medium that we're able to relay this information through that you find helpful. So please give me some feedback on this. Hopefully you do find it helpful. All right, that's it. Have a good week.